So an update is a relative term, and I must say that what I'm going to present are the things that I feel like I've been updated on in the last 2 years. So I hope that you have been keeping up with the field of uveitis, because there may be some, if you haven't been, there may be some gaps here that I'm going to skip over. But let me tell you what's different about the uveitis examination, and mainly this is improved imaging techniques. So wide-angle fluorescein angiography is an amazing tool in uveitis. The example here on the left is of a Biologic patient, and you can see very clearly the areas of non-perfusion and also the peripheral retinal vascular leakage. These things are likely to be missed if you don't use wide-angle imaging. And on the right, you have a patient with multifocal choroiditis, and you can see these minuscule active lesions that are hyperfluorescent, not scars, hyperfluorescent active lesions, and you really get an appreciation for that with this 100-degree field. Autofluorescence in OCT is a new diagnostic test for intraocular lymphoma. On the left, you can see the autofluorescence. Lymphoma cells are hyper-autofluorescent if they are at the level of the retinal pigment epithelium. They look bright. If they go into the retina, they may block and look black, so you can get this speckled appearance. But if you can correlate these hyperfluorescent lesions with the deposits that are underneath the retinal pigment epithelium, the confidence that you're dealing with an intraocular lymphoma is much increased. This is an interesting use of an OCTA. We had a man that we knew had Susac disease. He had had a small stroke. He had bilateral branch retinal artery occlusions. He had hearing loss. The diagnosis was completely confirmed. He was on 3 or 4 immunosuppressive medications, IVIG. He'd had pulse cyclophosphamide. He was on rituximab. And then he came in with symptoms that were classic for AMN. And you can see that he has the classic features on imaging of acute macular neuroretinitis. So it was very interesting to be able to tell the neurologist, we know you have this man almost on maximal therapy, but he's actually having a very small vascular occlusion that indicates probably he's going to break through and you need to adjust. Here are some of the deeper cuts through the superficial and the deep plexus of the retina, and you can see just basically here that this is probably a retinal affliction. The choriocapillaris was negative, but there's some irregularity here that indicates one of these very small defects in the circulation. I talked yesterday in the course about AMPI, and I wanted to bring this to you again because it's another very cool thing that you can see with OCTA. So late staining and fluorescein angiography is classic for AMPI. When you look at the avascular retina level on OCTA, what you notice is that it isn't completely avascular. It's avascular in the area that is normal, that does not have leakage, but you have all of these retinal vessels which are, I think, are a dropping and a collapsing of the outer plexus into that layer, into that segmentation scan where they really should not be. And if you look at the OCT, you can see why, because this is the OCT, and you can see that there's a dropping and a loss of the outer nuclear layer and the photoreceptor layers, so that that retinal plexus is being drugged down into the segmentation that will hit the avascular slab. Then if you look at the ICG, this is the choriocapillaris level on the OCT. Fabulous to know exactly where you are and what you're looking at when you look at the OCTA. Very different from what you see on angiography. The normal areas are here, perfused, they are light. On ICG, they are light, perfused, and these dark areas are where you have closure of the choriocapillaris in AMPI. It's the best demonstration that I have seen that demonstrates it's not a pigment epitheliopathy, it is a disease of the choriocapillaris. There are other clinical uses of imaging, and these were referred to this morning. The use of autofluorescence to monitor diseases like serpiginous choroidopathy and multifocal choroiditis. You look for hyper-autofluorescence at the borders of these atrophic scars. That's the next lesion that is going to appear. That's your indication that treatment needs to be increased. It's also useful to other types of imaging, useful for detecting neovascularization of multifocal choroiditis with the OCTA, and then assessing treatment outcomes. I now use wide field angiography on a routine basis to monitor how my patients with pars planitis and retinal vasculitis are doing, because I think it shows me things that I just cannot see with my naked eye, and I cannot intuit how they're doing without doing the actual testing. So I want to update a bit on the research in uveitis. This is mainly clinical research, huge progress. First thing that happened was the standardization of uveitis nomenclature. Sun1 facilitates clinical sites pooling data because now everyone grades the activity of uveitis in the same way. Sun 2 is attempting to get uniform case definitions for various subtypes of uveitis. There are about 29 types of uveitis that will have a distinctive profile of features. And so what they've done is they've collected cases by a number of people around the world. They asked them to use preferred descriptors, and now there's panel voting to say, yes, we agree that this is actually a case of punctate inner choroidopathy, or that this is actually a case of CMV retinitis. Unfortunately, the correlation is not very good yet. Clinicians seem to be calling things all sorts of different things, which means that if you're going to try to pool data and you don't have uniform case definition and entry into clinical trials, you're probably going to fail to show anything of use. And this strategy comes from the rheumatologic diseases, where, as you know, to be diagnosed with lupus, you have to have a certain number of factors on a very set list of features, and it's all been validated in some fashion, so that when you say this is a lupus patient and I'm putting this lupus patient in a clinical trial, you can be confident that that's actually what you're doing. We need the same type of thing in uveitis. There's been a large increase in randomized controlled clinical trials for uveitis. They've been successful in getting FDA approval in the United States for adalimumab and Ozurdex. The intravitreal injection of sirolimus is still in trial. They're having to redo some of the pivotal trials. And the IL-17 inhibitor was found not to be useful in uveitis treatment, which was quite interesting, but good that it was put to the proper test, and now it can be discarded and no longer investigated. So there are also a large number of collaborations between researchers in developed and developing countries. Indian uveitis clinics have tremendous numbers of patients, and it enables clinical trials to proceed by enrolling larger number of patients in a more rapid period of time, so you get your outcomes quicker. The research becomes more relevant in that fashion. There's also a trend in the literature away from small case series to hypothesis-driven prospective studies with sufficient patient numbers to give meaningful results. This is a good thing, because the uveitis literature up to now has not been particularly robust compared to other endeavors in ophthalmology, such as retinal diseases. The MUST Trials group is still going strong. They did a huge trial, randomized comparison between the fluorescein implant and systemic immunosuppression. It's now in year 7. They found that patients who got the implant are perhaps seeing 5 letters less than the patients who got the systemic immunosuppression. Most of the uveitis doctors are like, okay, so what, who cares? But it's amazing that you could have the integrity of data and the quality of research to be actually follow patients for 7 years and be able to come to such a conclusion on such a fine point of a clinical outcome. They're doing other trials, comparison of agents to treat CME, and they're considering doing pars plana vitrectomy versus medical management to control intermediate uveitis. They published a lot of papers on uveitis, vision loss, CME, epiretinal membrane glaucoma, all sorts of ancillary issues in uveitis. Now, how about an update on the medical therapy? Mainly, this is targeted therapy with biologic agents, and I'm sure you're aware of it. We follow the example of rheumatology and what they do with their rheumatic diseases. We are total beneficiaries of their hard work. Mostly we're targeting cytokine molecules, principally TNF-alpha, IL-6. There are other strategies. These JAK inhibitors are being used in rheumatoid arthritis, may have some applicability in uveitis. And then there's targeting of cellular targets as well, not just the products of cells, but the cells themselves. Rituximab is very efficient at removing CD20 positive B cells from the circulation. You can use it in recalcitrant Behçet, use it in systemic vasculitis, worked great in granulomatous polyangiitis, and in a very recalcitrant, very mature chronic uveitis patient who's already been through a lot of treatments. Rituximab can will often be the ticket to get them out of the mess that they're in and get their uveitis to go quiet. So TNF inhibitors are really the most well-known of all of these agents. If you have a spondyloarthropathy and are having attacks of uveitis and you go on adalimumab, your frequency of attacks goes down by 50%, reduced by 75% by infliximab. And currently, infliximab is almost first-line therapy for Behçet, skipping the drugs and going directly to the biologic agent. Adalimumab is useful in children with JIA. That's been proven in a very nice study that they actually stopped early because the benefits of adalimumab were so obvious compared to the treatment with placebo when combined with methotrexate. So what is the current state of the art of biologics? It's routine. We add a TNF inhibitor in pediatric uveitis after failure of methotrexate. It's routine now that I have access to adalimumab, that it's approved for me to be taking patients with persistent active intermediate posterior panuveitis off their agents, their medical treatments, and adding or substituting adalimumab. Patients with Behçet disease, I said, are often treated with TNF inhibitors, sometimes with interferon, and there's a large number of alternative biologics if the TNF inhibitors don't work, which they don't in about 20% of patients. Lots of unknowns in biologic therapy. How do we predict which patient will respond to which agent? How do we improve the remission with these agents, which unfortunately tend to need to be given for long periods of time, very difficult to taper them? How do you sequence using drugs and biologics? Do you add one after the other? Can you treat someone with biologics for a while and put them back on drugs? And how do you monitor concomitant drug therapy and decide what to use in patients? So, for the rest of these topics, there's two more, actually three more, and these are research topics. These are my notes that I took from the International Symposium of Uveitis, which occurred this last August. The microbiome was one of the hot topics that we discussed there. It's the total bacterial load of each human. Your changes in your life, antibiotics, your treatment, your diet are important in altering it. And if you intentionally alter it, it may alter the disease course, as has been done in ulcerative colitis. But it's unknown whether it has a role in uveitis. In animal experiments, which is the experimental autoimmune uveitis model, Rachel Caspi is able to show that in the gut microbiota, there's signaling that activates retina-specific T cells and produces uveitis. Russell Van Gelder is interested in what he calls the virome, our total burden of viral disease. He uses next-gen deep DNA sequencing. He can assay for all biologic organisms and also for viruses. And he's found to have very interesting findings of this torque-tenovirus. It's implicated in Shapu, which is the seasonal hyperacute panuveitis in Nepal, a very devastating disease of children, and that it's found in the majority of cases of sterile endophthalmitis. So whether it's a facilitative type of virus or whether it's actually causative is not known, but it's present and it's something that most people have never heard of before. The relationship of infection and uveitis is very interesting. It's something that has not been really ever discarded by uveitis specialists, thinking that there may be infection at the basis of many types of uveitis. This may relate to tissue damage or actual peptides and molecules that are associated with the infections that set off. And anecdotal associations have been noted before with herpes and Behçet, Lyme disease and Behçet, and then there's this antecedent conjunctivitis and urethritis and reactive arthritis, which has long been known. I can see once again I'm running out of time. I'm trying to figure out the best way to cut this short. I think I'll finish with this because it's really interesting, and then we'll leave off the other interesting topics at the end. There's an issue with either innate or adaptive immunity being more important in uveitis. Autoinflammatory disease definitely exists. It does not require a specific antigenic target. So this is seen most clearly in uveitis that is associated with genetically mediated multi-system inflammatory reactions. And these are diseases like CAPS and SINCA, which you may see in very young children who have multi-system involvement but also have uveitis. It may also be involved in unprovoked inflammatory reactions in the body. It involves usually an increased release of IL-1 beta, and it seems to be the only type of uveitis that will respond to those inhibitors. And some of the uveitic diseases that we see may be both autoinflammatory and autoimmune, which is why we've had such a difficulty in actually controlling them and understanding them. These would be Behçet disease and HLA-B27 associated uveitis. I think that signals for innate immunity, let me see if I can get one more slide in. Nope, not going to be able to do it. Signals for innate immunity, and assuming that that is a problem that's going on, may signal a need to use biologics rather than just immunosuppressive drugs, because the immunosuppressive drugs will only hit the adaptive immunity component of the inflammation. Thank you very much. Okay.